everyone. Welcome to our webinar series 2020. This is our 9th talk. And today we are joined by Dr. Mamatha Rao. She's a radiologist and she's working in the NHS. Welcome, Mamatha, to our webinar series. Good to have you here.
Thank you, BDB. I am not an expert in AI radiology, but we all have been dabbling. We don't have an option but accept and embrace AI in radiology. Apart from rest of what is happening in rest of the medicine. So I'm happy to give a brief snapshot of what is happening with respect to AI in radiology. Next slide.
Before you get started, Mamatha, just a little bit background about yourself and then we'll go on to the slides, okay?
Yeah, sure. I am a breast radiologist and a general radiologist. I have 2 kids. And my husband is also a radiologist, but he's a MSK radiologist. I work at Dartford near London. I have been a consultant for 12 years now, and I am basically from Mysore, India.
This is my screen, so I will run it. You prompt me.
Take it.
Sorry, folks, a little bit of a hiccup there, but we are ready to go. Yes, Mamatha, carry on.
Yeah, computer problems.
AI problems.
Okay, so artificial intelligence is nothing but is basically a term where the machines mimic the cognitive functions of humans. So in this context, we are using AI for learning and problem solving. Next slide. So aims of this talk is to tell you a basis for application of AI in radiology, immediate ethical and professional impact, and also possible future evolution. Next slide. So AI is already happening in rest of medicine as well. Fundoscopy is already AI based in more fields and UCL in London. Echo, I think tests are going on whether paramedics can do the echo and send it to the central hub, and that will speed up the patient management. And lung sounds as well, tests are already going on, and heart sounds, that is murmurs, and also digital pathology. So basically anything like sound or image, if it can be digitalized, then there is the chance that it will be machine learned, and it can be performed by AI. Next slide. So sorry, next slide, please. Yeah.
Papa, I don't want to come inside. Tell me fast.
Some of the highest paid doctors become obsolete, is what they are saying. But like radiologists and pathologists. But I don't think that is entirely true. Next slide, please. So is the future of radiology in the hands of robots? We'll see that. Okay, so but radiologists are not unfamiliar with AI. This paper is from 1963. It was published in Radiology, which is a reputed journal, about more than 50 years ago, and that said that coding of X-rays for computer analysis was already being applied to lung cancer. So they were conducting some, they were testing some algorithms. So, but it was only around 2012 to 2016 that it took off, and the application became more apparent that it could be put to clinical use. Next slide, please. So how do we get the machine to learn? It can be, learning is usually can be unsupervised, reinforced, supervised or semi-supervised. Next slide, please. So in unsupervised learning, the agent, that is, whether it is cloud-based or whether it is just application, it learns patterns in the input even though no explicit feedback is given. So that is yet to happen. In reinforcement learning, the agent learns from a series of reinforcements, that is rewards or punishments. And supervised learning provides the agent with a teacher's input that the agent then learns. And in semi-supervised, few teachers' inputs are also given to the agents. Next slide, please. So in radiological context, this might mean confirming diagnosis suggested by AI by comparison to pathological or surgical diagnosis. So ground truth is the data assumed to be true, not my opinion. I might say, oh, this is cancer, not whereas AI is saying that this is consolidation. So it is not my opinion, it is pathological or surgical diagnosis. So basically machine learning has been likened to training a dog, that is reinforcing good behavior, ignoring bad, and giving best enough practice to work out what to do as a job. Next slide, please. So there are various terms that we can use in artificial intelligence, machine learning, as well as deep learning. Artificial intelligence was what was used early on, and it is mostly deep learning that we are using the term as. Next slide, please. So the term machine learning implies the situation in which the agent is learning if it improves its performance on future tasks after making observations about the world. So agent can be anything that can be viewed as perceiving its environment through sensors and acting upon the environment through actuators. That is basically anything that can sense. It can be sound, it can be image, or anything that can be digitalized, basically. Next slide, please. So deep learning is a subset of machine learning and is the basis for most of the AI tools for image interpretation. Deep learning means computer has multiple layers of algorithm interconnected and stratified into hierarchies of importance, like more or less meaningful data. We tell the computer whether it is meaningful, what it is interpreting, and whether or it is less important. These layers accumulate data from inputs that we provide and provide an output that can change step by step once the AI system learns new features from the data. Such multi-layered algorithms form large artificial neural networks. We call this as CNN. So artificial neural networks is, the CNN is again a very common term we hear in the AI world in radiology. Next slide, please. So artificial neural networks can be trained using training data sets from which the network learns. In radiology, these usually consist, at least initially, of hand-labeled image data sets used by the algorithm to improve its fit to match the ground truth. Once a network has been trained using a training data set, it would then be tested using a different set of data designed to evaluate the fit of the model to new data. So in this step, it is common to observe overfitting of the model. Basically, what we are saying here is, say we take we take a lung nodule detection as the job here, and we show the AI, the agent, what a lung nodule looks like. And then, there might be a granuloma which looks similar to a nodule. which is basically a spot of calcification usually, and which is not important clinically. So we can train it to um, detect it, and then in the next layer we can put the specification that if it shows calcification, to mark it as less important. So basically, what we are saying here is that the machine learning or the AI will pick up a lot more overfitting. So it will put a lot more X-rays or CTs into that pool, calling them abnormal before um, before we sort of filter it even more. Next slide, please. So as a general rule, the deeper the network, so the more and more layers, that was the correct slide, Bidhi.
Sorry.
Yeah, this is fine. So the best solution for reducing overfitting is to obtain more training data. So for example, if we are training the AI to detect, to evaluate cysts, no, sorry, go back, please. Yeah, this is fine. So the more deeper the layers, yeah, this slide is fine. Thank you. So basically, if we are showing the agent to recognize a cystic lesion on ultrasound, on training data sets, the lesion could be perfectly cystic, but to make it more intelligent, we can add some internal hyperechoic spots caused by artifacts. And so it will then learn that it is a non-perfect cyst in the validation data sets. So next slide, please. So basically, as a general rule, the deeper the network, that is more layers, and the more rounds of training, the better the performance of the network. So there was various thousands of publications have come out which show that how AI is very good compared to radiologists. But what is important is, next slide, please. What actually they should be saying is that algorithm can detect pneumonia from chest x-rays better than radiologists. Not algorithm can diagnose pneumonia better than radiologists. So, algorithm can only identify what we have taught it. So, if we have made an error, or if we have, had any bias in teaching it something, then it will over detect or under detect. This will become more and more important because when data is being handled by companies like Google or Amazon, who are also linked to insurers, yeah, that is when we have to be careful. Okay, next slide, please. So tasks of radiologists are many, that is including education, consultation, that is protocoling, which scan to perform, appropriateness, and the review of prior imaging, and also at image acquisition, whether there is specific protocol to be performed, image optimization, whereas AI mainly helps in detection of anomalies, measurement or segmentation, and classification of images, and also it can help in reporting. We'll come to each one in the next few slides. Next slide, please. So this is basically the same. It can help in various things, that is a patient being referred to the provider, image appropriateness, utilization, scheduling, image protocol selection, hanging protocols, reporting, as well as communication and billing. Next slide, please. So AI helps with reduced acquisition time. So there's already collaboration between NYU and Facebook to make MRI scans 10 times faster with neural networks. So there's automated calculation of missing information gaps with the direct learning. So they took 10,000 clinical cases with 3 million images. Next slide, please. So the first slide shows a standard high dose CT, and middle shows CT which was produced with low dose, and the middle CT, I know the images are not being projected very well, but image in the middle has a lot more noise and less clarity compared to the image on the right. So the right image, which is labeled as pixel shine, that one is obtained at the same dose as the one in the middle, but it shows clarity comparable to the image on the left hand side, that is the FBP image. So what it has done is taken guessed the information that we had lost and the noise that we got from reducing the dose. It has guessed and it has filled it up itself and removed the noise basically. Next slide, please. So automated hanging protocol is already in place for most of the radiologists who have PACS. So radiologist opens the study and the machine learning assistant creates the optimal hanging protocol. So radiologist makes the report and sends it to RIS. So automated hanging protocol is very commonly used, even even personalized. One person may like a full screen image to start with. Another person may want all the series divided as 4 on the screen. So we can personalize it, and mammograms have their own way of being hung as well. So this makes life of radiologists very easy. Next slide, please. Yeah, so triage and prioritization. AI can be trained to detect intracranial hemorrhage. So it can, when it detects the hemorrhage, it can bump up the CT for reporting more urgently on the list. Next slide, please.
One minute.
So the semi-automation of reporting can be in various ways. Automated inclusion of quantitative data and radiomics. So frequently when we measure the lesions, it already detects that it is more than one measurement that we take of the lesion usually. So when we go to type the report, it can tell us the quantitative data. And automated computer aided reporting, again, this is mostly one word at the moment. It says whether something is abnormal or normal. Automated scoring, whether it is BIRADS or PIRADS, I think that is again based on what we are using locally. It can tell us whether we have missed out anything in the report. That is usually reported in that kind of scan. And also presentation of guidelines depending on diagnosis. So automated labeling and coding of findings, inclusion, and registration of common data elements. So basically, it sort of suggests what keywords to put in, like when you upload something to Google or YouTube, it suggests the keywords. So next slide, please. We'll jump this slide. Next slide, please. We'll jump this slide as well. I think I have spoken already about that. So next slide, please. Go to use. Next slide. Yeah. So the use case describes, basically use case is a term that we use for the specific clinical application of AI in radiology. Use cases can be considered as precise scenarios, whether, just basically yes or no scenarios within radiology service where automation could add significant value and establish standards. Next slide, please. So the main difference between CAD, that is computer assisted diagnosis, and true AI is that CAD only makes diagnosis for which it has been specifically trained and bases its performance on a training data set and a rigid scheme of recognition that can only be improved if more data sets are added to the CAD algorithm. True AI is characterized by the process of autonomous learning without explicit programming of each step, based on a network of algorithms and connections similar to what humans do. Earliest clinical applications were more of computer aided detection. But now we use the term interchangeably, actually. Next slide, please. Many of the recent applications of AI include pediatric bone age machine learning based on plain radiographs, breast cancer detection in mammography and MRI, chest radiograph interpretation, liver lesion characterization on ultrasound and CT, brain tumor, and also prostate cancer detection. A step beyond disease detection is disease classification into low or high risk with a good or poor prognosis. Much of the work in this field has been in brain imaging in both benign and malignant disease. There's been considerable effort to develop AI classifiers in pediatrics where brain mapping and functional connectivity can be linked to neurodevelopmental outcome. Basically, it measures how well the person can perform based on what criteria it has seen in the scan. Next slide, please. In a study evaluating resting state functional MRI data, that is, where the baby is not stimulated in any way, resting state, MRI from 50 preterm born infants were assessed and compared with term infants, and there was 84% accuracy on the diagnosis of how well they did based on inter and intrahemispheric connections throughout the brain. And also in multiple sclerosis, it has a lot of research has taken place. A classification of glioma grade based on MRI images has been attempted with some success. Next slide, please. So automated segmentation is also another area where vital information on the functional performance of tissues and organs, disease extent and burden information is easily presented to the radiologist. So people have developed a deep learning and deformable model for left ventricular segmentation from cardiac MRI data sets. So there is automated calculation of clinical indices such as ventricular volume and ejection fraction. Multiple studies have also been published about abdominal, can be liver, pancreas, vessels, as well as pelvic, that is prostate, organ segmentation using a deep learning approach. Next slide, please. A similar approach has been applied to segmenting brain metastases on contrast enhanced T1 weighted MR imaging for planning for stereotactic radiosurgery. Next slide, please. Other applications of AI in radiology is that usually AI we use for lesion detection and characterization, assessment of response to treatment. But AI is likely to impact other areas of radiologists and other healthcare professional work as well. Examples include, next slide, please. Radiomics, that is extraction of features from diagnostic images, the final product of which is a quantitative parameter measurable and mineable from the images. A radiomics analysis can extract over 400 features from a region of interest in a CT, MRI, or PET study and correlate features with each other and other data far beyond the capability of the human eye and brain to appreciate. Such features may be used to predict prognosis and response to treatment. AI can support analysis of radiomics features and help in the correlation between radiomics and other data, that is proteomics, genomics, liquid biopsy, etc., by building patients' signatures. That is basically patient passport kind of thing, and so it has learned what it showed. Yeah, this slide is fine. So imaging biobanks are basically a set of data where the computers store a large amounts of data. And in radiology, the need to store native images and the big data derived from quantitative imaging represents the main cause of PACS overload. But quantitative imaging can produce imaging biomarkers that can be stored, organized in large biobanks, and it is available to be processed, analyzed, and used to predict the risk of disease in large population studies and treatment response. Large biobanks also have the potential to become the repository of digital patients, that is avatars or digital twins of humans that can be used by AI to perform simulations of disease development and progression. Moreover, imaging biobanks would become a necessary infrastructure to organize and share the image from which AI models can be trained. Next slide, please. So Google and others believe that delivering AI through the cloud will be a big lucrative trend in computing in the coming years. Next slide, please. Amazon as well is making huge investments, and it says that Amazon. The first, it is happy to give insurance for the Amazon employees. Basically, they say we have the size of data for influencing the insurance companies. The problem of the rising costs in healthcare is only becoming worse. Innovation is necessary, is what they say. So basically, they are saying that those people at risk should be paying more insurance than pay those people who work hard at maintaining their health and things and who are less likely to develop disease. I think that is a iffy area, isn't it? It is basically going into murky territory. So retrospective quality assessment is also possible with AI. So has the doctors' performance can be easily assessed. Next slide, please. But who has the medical legal responsibility of interpretation of these images? AI may bring new features that radiologists cannot detect or quantify, but a computer-assisted diagnosis as being applied in CT colonography, lung cancer, breast cancer detection can be used as first reader. But that is not recommended by literature because that can influence the human radiologist. The CAD being the second reader is mostly recommended as a, and also as a concurrent reader, where it can make few recommendations, but never as an independent reader of studies. Next slide, please. So who is responsible for the diagnosis, especially if it is wrong? Whether it is data scientists or manufacturers involved in the development, marketing, and installation of AI systems who have to take the responsibility, or is it the primary agents of interpretation and the doctors, who will be held accountable? If radiologists monitor the AI system outputs, and still have a role in validating the AI interpretations, do they still carry the ultimate responsibility even though they do not understand and cannot interrogate the precise means by which a diagnosis was determined? This is again a murky territory, because it is not easy to understand how and why important decisions were made by the AI. Most of us would be content if we were told by a doctor, I don't know why you're ill, but my computer says take these pills, or I don't know why you are ill, but my computer recommends surgery. I don't think any of us will be happy to go with such a scene. So ethical issues. Next slide, please. I'm going to just touch on these things: human bias, transparencies of algorithm, and also collective brain. Next slide, please. So human bias and transparency. Training data can be biased. Say Google photo image classifier tagged a black person as a gorilla. So what is the real person? It can, we can tell it that a gorilla looks like this, but it can also make errors, and whether and how it lands us in the soup, we will have to rescue ourselves, really. So you still need a radiologist at the end of beside the agent. So what is the real purpose of the algorithm? That is the transparency of a black box. So even something basic, simple like Facebook or Zoom or any application, we are sure that apart from what is being projected to us, there is a lot of information being gathered about us for use commercially. So it is the transparency is important as well, and that is something we need to keep an eye on. Next slide, please. Next slide, please. So automation bias, that is automation induced complacency. So the tendency to over rely on automation, failure to recognize new errors that AI can introduce. So we can a lot of us say radiographers or radiologists, because we have been trained, we can we still have the education and to catch something if it goes wrong. And I think that education should carry on. It should not be lost because we have made it not, we don't have a requirement for it on day-to-day basis because of AI. Next slide, please. From a factory worker to consultant, avoid, AI can help with anything that is a repetitive task. Add expertise where it counts, and exploit modern technology for functional information. Next slide, please. Next slide. Yeah. So the third revolution in radiology, that is machine augmented diagnosis, is improving the performance of radiologists by enabling earlier detection of disease, enabling quantitative characterization of focal and diffuse disease, reducing error rates, as well as optimizing therapies at individual patient level. Next slide, please. So how do we decide what to push or what to pull? So radiologists will decide what applications are being used and how. They will also push the right techniques. Do radiologists know what clinicians want? Will they accept it? Example, perfusion imaging. And also pull, that is radiologists who do not adapt. And if clinicians start using it first, or referring clinicians, insurance companies, authorities, patients will demand radiologists to use AI. Next slide, please. I saw, sorry, this is a very busy slide. Next slide, please. Yeah, so there is a need for access to large volumes of data. So all these companies, you saw on the previous slide, that is a small number of major companies that are into this business. And it is basically they are out to make money, and it is commercial, but it is being trained on patients and radiologists, and whether who is going to be there is who has ownership of imaging data sets, and whether each patient whose image is being used for training, do we need to take consent? These are the murky areas. And also the whether whether any remuneration that the AI agent is making from this, whether that should go back to the patient or the clinician who is feeding back, or even to the radiologists, or things like that. Next slide, please. I think we can skip this. Next slide, please. So possible scenarios for integrating AI. So AI on demand, or automated image analysis, or automated routing to EPR. Next slide, please. So AI on demand is where for a single image or a series of images, that is PACS, or a radiologist, images on PACS, the radiologist sees, and then it goes to the AI server, then to the PACS, RIS, and EHR. So radiologists would be in control of asking the relevant AI interpretations. Say, for example, there is a CT chest abdo-pelvis. I can ask AI to say, have you seen any lung nodule? So that is me asking AI on demand. Next slide, please. So automated AI image analysis, so where it is already performed, and then it helps prioritize the reading order. So like I said about the CT brain showing bleed. Radiologists views the AI findings before the and also radiologists views the AI findings before the final report is made. So in case somebody has um, reported the CT brain with bleed in one area, a small spot in a different area may have been missed, because it is a common error for us to sort of have the satisfaction of search. So radiologist is then able to ensure accuracy and validate the report. So that is just basically a feedback, immediate feedback process. Next slide, please. Automated routing, but the results are generated and automatically routed to RIS or EPR. but it requires discrepancy management. So there is a lot of risk. It might increase calls to radiology reading room because, say in the hospital that I'm working at, already a lot of chest x-rays are just labeled as abnormal, normal or abnormal. So, they usually the doctor, when he sees that it is abnormal, he doesn't know what is the importance of that phrase, and it can lead to the doctors making a lot more, giving anxiety to the clinical situation. Next slide, please. So AI algorithms should also be interoperable. So that is, AI should interpret, images based on whichever the last image was obtained at, and compare. And radiologists have to determine the best model for implementing the AI, when, how, and what purpose, what to do with the results and reports, and how to validate the apps, what quality criteria should be implemented. Next slide, please. Next slide, please. We'll go to the slide where AI is roaring at the start. Yeah. So what is the fuel for AI? AI is basically from the sharing of data internally and externally, vetted and annotated data. So what is needed for it is the IT infrastructure in the hospital, that is interoperability, connected and communicating systems, optimal integration in radiological workflow, and also traffic regulation, that is, people to manage all this. But the responsible pilot for all this still remains the radiologist, because there is somebody who needs to handle all this. There is a lot of work involved here. Next slide, please. So what role should radiologists play? So many of the single routine tasks in radiology workflow will be performed faster and better by AI algorithms. But the role of the radiologist is a complex one, focused on solving complex clinical problems. The real challenge is not to oppose the incorporation of AI into the professional lives, but to embrace the inevitable change of radiological practice, incorporating AI in the radiological workflow. The most likely danger is that we'll do what computers tell us to do because we are awestruck by them and trust them to make important decisions. The radiologists can avoid this by educating themselves and future colleagues about AI, collaborating with researchers to ensure it is deployed in a useful, safe, and meaningful way, and ensuring that its use is always directed primarily towards the patient benefit. In this way, AI can enhance radiology, allow radiologists to continually improve their relevance and value. Next slide, please. So, hype around the new technology, often commercially driven, may promise more than it can deliver and tends to underplay difficulties. It is the responsibility of the clinical radiologists to educate themselves about AI in radiology, and in turn to educate those who manage and fund our hospitals and healthcare systems to maintain an appropriate and safe balance, protecting patients while implementing the best of new developments. However, radiologists' working lives will undoubtedly change in this area of artificial intelligence. Next slide, please. But will radiologists be replaced by AI? The simple answer is no. Next slide, please. artificial intelligence will not replace radiologists. Yet those radiologists who use AI will replace the ones who don't. Next slide, please. Thank you. Any questions?
Thank you, Mamatha, for giving a very wide overview of artificial intelligence in radiology. As we wait for the questions to come in, I will just kick it off. So basically, what exactly is the difference between machine learning, algorithms, data? What is the link actually? A little bit on that for the uninitiated.
I think it depends on what computers can. It is beyond what I understand as well. But from what I there is very basic level of understanding that even I have about this, because I'm not into this AI field. But it is more like like Google guessing what comes up next when you start typing in its box, or in Zoom how they harvest the data when they we know that it happens, but it is beyond what I know actually.
Yeah, like Facebook tagging the images and saying that, okay, this is Biswajit, this is Mamatha.
Yeah.
Or, in Facebook, it circles the face of the image so that you can focus on it.
Yeah.
So these are basically algorithm-driven functions of Facebook and Google. That's what you're trying to say. Yeah. And so in medicine, what we are doing is we are collecting the images, and then the computer is analyzing them and making an algorithm which gets better and better as you train more images. Mm-hmm. And then it's outputting something. So it's something like pattern recognition, right?
Yeah, that's right. Yeah.
So either the algorithm identifies a particular pattern to be associated with, like you said, for example, in a mammogram, whether it's malignant or whether it's benign. So it identifies a particular pattern in the image and then outputs it as whether malignant, yes or no. That's one way of putting it. The other way is, like you said, is to classify it into different categories to know which category the RADs, BRADs and all that, right?
Yeah.
So there are a couple of important mentioned is looking beyond the eye, because the human being has a restriction in terms of its vision. Though it can see a lot, there is a lot of, the computer sees the image in a much different way than the human eye can. Right. Okay. There are a couple of questions here. Dr. Manjeet, he's our anesthetist. He's asking, hi, if you put the clinical data of patient and then you use AI, can it give us a better result? I think what he means is that you have clinical radiological image. Are there algorithms that are using images plus clinical data? Will it make the output better?
Yeah, it should. I think, like I said, there are millions of papers already on this. And that is a important area where the EPR, electronic patient record, which has access to the biomarkers like blood results. Say on a chest X-ray, there is there is a patch. Whether it is consolidation or mass, it is based on the white cell count, CRP. That is definitely a possibility.
Right. Yes. So there are some applications that are working on it. Dr. Srinivas Bapu, he's our ENT consultant. He's asking, is AI put to practice in any radiology center or hospital so far?
Yes. We use the term AI very broadly. Since last 15 years or so, computer assisted diagnosis is already taking place in mammography as a second reader, sometimes as first reader. This is in breast screening, where a lot of the women from the population are screened, and there is a lot of images to go through, and there is a shortage of breast radiologists. So computer assisted diagnosis is already taking place in UK, and I'm sure in in various areas of the world as well, including Europe, where in mammography it has already been used last 10-15 years. And at the moment, a lot of hospitals in the UK are also being used to collect the data for things like chest X-ray reporting. This is it is all, basically it comes up with a yes or no report. It says some chest X-ray is abnormal, and that is all it says basically. And we have to, we then report it as what is abnormal about it. But it tells the clinician that there is something abnormal. That's it.
Yeah, apart from just detecting what is wrong in the X-ray, it can also help in the workflow, like you excellently mentioned in the slide, from factory worker to a consultant. Because often when you are seeing X-rays, for example, chest X-rays, there are so many hundreds and hundreds of normal X-rays, and you are simply writing a normal report, and often you end up using a template to just generate the normal report. So the algorithm can help in this situation by bringing all the abnormal X-rays to the top, so that the radiologist can quickly look through that X-ray because it's been tagged abnormal. So and generate a report, because that's what basically the clinician is sending the X-ray to the radiologist for, to find out whether there is any abnormality and therefore report that. So improving the workflow is also an important part, and not just arriving at radiological diagnosis, so to speak. Yeah. So basically, AI, as we know, like you mentioned, has been there in the medical field for quite some time now. But I think it is taking a leap now at the moment, probably.
Yes, I think that's thanks to our friends in the engineering and computer department, really, isn't it? It's amazing in this world lockdown how we all are still connected, and I'm presenting to people who are based in, thousands of miles away. It is amazing,
Yes.
and thanks to them, really, isn't it?
Yes, that's right. I think computing power has become cheap, storage has become cheap, and I think technology is more. People are into technology more, and I think that is making it useful. So one aspect you said is about bias as well, that the algorithm itself could be biased as well. So it depends upon what we call as GIGO, garbage in, garbage out. If you feed wrong data, obviously you will get wrong output.
Yeah, that's right. And also, when we are looking at only a particular area, the AI is, still at initial stages where it is only manipulating and diagnosing only one certain area. Whereas, we as doctors, we look at the whole person. It might say, oh, the heart sounds are normal, and lung sounds are normal, so this person is normal. But he might have a head injury and something else might be completely abnormal. So we still need we still have a long way to go where it can totally replace a doctor.
Yeah, obviously it cannot replace the doctor.
Everything,
Yes, yes. I think that's the fear, basically, that that's the way the media portrays it, that artificial intelligence means a robot which is doing the work of a human being. But it's not exactly like that. It's replacing certain, it's enhancing your workflow, making your job easier than like before we had the typewriter. Now we have the computer with the same keyboard sort of thing, but doing much more than what a typewriter could achieve. Yeah. So any other questions? Anybody else has questions? That was an important point also about first reader, second reader, because I think relying, like you said, algorithms are still not yet there. So relying on it completely as a first option, I think, is not required. And the second reader, that is, the radiologist asks the algorithm for help if required. I think that was a very good point you made. Also, you made a good point about the automation bias, that we have to always watch out for getting lazy. If the computer is doing the job, you might not look out for the situations in which it may be making an error, just like we make an error and we are always on the watch out for it. We have to watch out for errors from the side of the computer. Okay, I think that is it. Let me just check the chat box. Sometimes people put questions on the chat box as well. Let me see if somebody has got anything there.
Sorry, it overran significantly. I've taken almost.
No, that's all right.
Time, isn't it?
No, that's fine. That's fine. Great. I think Dr. Smita is saying very interesting topic. Great presentation, Dr. Mamatha. Thank you. I think, yes, we have rounded up everything. Thank you, Mamatha. Thank you for joining us today for the webinar. It was a very interesting topic. This is a topic very close to my heart, actually. But anyway, that will be a discussion point some other day. Thank you, Mamatha. Thank you for joining us. Thank you, everyone, for making it to the webinar. This is the last webinar in this series, and we'll say goodbye for today. Any last words, Mamatha?
It was lovely to talk to all of you. We'll keep in touch. Maybe I can attend more webinars and keep learning as well. Take care.
Thank you.
Okay.